immunocompromised host, and the objectives of this lecture would be: number one, to define and identify an immunocompromised host. More importantly, understand the challenges in identifying infections in the immunocompromised host. In general, understanding the epidemiology of infections in the immunocompromised host, and also learn the general strategies for management of infections in these immunocompromised patients, and develop an approach in managing patients, particularly with febrile neutropenia. Now, when we say immunocompromised host, we should remember that immunocompromisation may be congenital or acquired, but in this lecture I will be focusing only on acquired immunocompromised status in some hosts, and this can happen due to a variety of reasons. One, it could be from alterations in any of the factors that assist with immunity, whether it is the phagocytic component, cellular immunity or humoral immunity, which can increase the risk of infectious complications in these patients, or it could be an alteration in the skin or mucosal barriers that may permit the microorganisms and lead to either a local infection or a systemic infection. Now, what are the various reasons why someone could develop an acquired immunosuppression? Now, the first thing we should remember is that there are several infections, particularly the chronic ones, that could by themselves lead to an immunosuppressed state. Although we often think about the human immunodeficiency virus, the HIV or the AIDS, we must remember that there are several other viral infections like hepatitis, herpes, some other bacterial infections, particularly the chronic bacterial infections, including tuberculosis, and parasitic infections that could lead to a state of immunosuppression which predisposes the patients to other infections. Secondly, not to forget malignancies, and when I say malignancies, I mean both the disease by itself, which could be the lymphomas, leukemias, myeloma, solid tumors, any of the malignancies, but we should also remember that it is not just the disease, but the treatment, the chemotherapy could also lead to a state of immunosuppression. Now, the more important chronic diseases that we all deal with are disorders of biochemical homeostasis. Although it sounds fancy, I mean any disorders in metabolism or changes in our body, which could include diabetes, which is rampant in our country. We are one of the capitals in the world, diabetic capital in the world. Chronic kidney disease, chronic liver disease, any state of malnutrition could all be contributing to immunosuppression. And when I say malnutrition, the protein energy malnutrition leads to several changes in our immune mechanisms in our body. We should also remember that immunosuppressive therapy, which is used for whatever purpose, whether it is for autoimmune diseases like lupus, rheumatoid arthritis, which again the disease itself could lead to an immunosuppressive state, and also the treatment that we are giving. Trauma patients whom we often encounter in the ICU may also have a reduced immunity, and this is not something that we think about because a lot of the times these patients have been otherwise well, but the state of trauma, the polytrauma itself, could lead to some immune suppression which could predispose them to more infections. Of course, transplants, which is whether bone marrow transplant or solid organ transplant, or the treatments that we use for rejection, could all lead to immunosuppression, but this will be addressed in detail in a different lecture. We should also think of some other common situations like pregnancy by itself could be a state of reduced immunity. Aging as a process, we all have reduced immunity as we age. Stress due to any reason, I mentioned polytrauma, but stress due to any factor, whether it is in the ICU or chronic, could also be leading to immunosuppression. Splenectomy done for any reason or a functional asplenia, when the spleen is not functional, could lead to a state of immunosuppression. Now, how do we approach these patients, the immunocompromised patient, particularly when you suspect that they have an infection? Of course, we need to find out the cause, why they are immunosuppressed or immunocompromised, why they have developed an infection, what are the predisposing factors, what are the underlying diseases, are there any therapeutic interventions that have been done for these patients that could have led to further immunosuppression in them. And we also need to come up with an anti-infective strategy. broadly sounds easy, but it could come with its own challenges, and by that I mean that in a patient who is immunosuppressed, a lot of the times the standard signs and symptoms that we look for in infection may be blunted or even muted completely. So, they may not mount a fever response, which we classically look for. They may not have all the classic features of the SIRS when you examine them in the ICU. So, that is something that we need to keep in mind, where we need to look for more subtle symptoms and signs in these patients. More importantly, when we do not have adequate signs and symptoms, we often rely on the microbiological confirmation, and here again lot of the times the microbiological confirmation in these patients could be in less than half of the patients who actually have an infection. And if and when we grow them or when we find the microorganism, a lot of the times it may be difficult to treat organisms or very unusual pathogens that we often may not encounter in other patients. So, how do we evaluate them? What are our diagnostic strategies for evaluating these patients when they have an infection? Of course, like in any other situation, a careful history taking, particularly looking for why they were immunosuppressed and what could be done to improve their immune status if at all possible. Extensive physical examination, and I can't stress on this enough, primarily because, as I already mentioned, a lot of the times these patients have blunted inflammatory response. They may not mount fever, they may not mount the SIRS response, they may not have a skin rash that we often look for. So, you need to keep all those in mind and do a significant physical examination to find out if there is any obvious source or reason why they have developed the infection. You also need to look for some unusual manifestations. Sometimes these immunosuppressed patients may have a secondary malignancy that could also be related to an infection. So, you need to keep those unusual manifestations in mind. And when we order the diagnostic tests, and I will stress on this in a further slide once again, yes, we need to order the appropriate microbiological examinations, but remembering that the positivity may be less than 50% of the patients, and we may be isolating rarer organisms. We need to do antigen detection tests, and this needs to be stressed over and over again, because when they are immunosuppressed, they may not mount an antibody response, and a lot of the times you may need to do antigen detection tests. We do order serological tests. Keep in mind that it may not come up positive even when a patient has an infection, and that is something that is important to keep in mind when you are managing these immunocompromised hosts. We may need to do various imaging techniques much more at a lower threshold than we would with other patients. Remember that the etiology can really be anything. I mean, I have stressed on this over and over again, that the infectious pathogens that may be isolated may be rarer organisms, and something that we do not often imagine. Think about the risk factors, and we need to look at what was the source or exposure to infectious pathogens, whether it was endogenous or exogenous. Look for skin barriers breakage, mucosal barrier breakage, and also think about the state, or what we call net state of immunosuppression, and I will focus on this separately in a different slide. Remember that we may not isolate organisms, but also when we isolate them, it could be rarer organisms, but it could also be polymicrobial infections, which are more common. Of course, that is a situation that we often face in the ICU, and we need to have an aggressive approach to diagnosis, and may have to have a lower threshold for doing imaging techniques like CT scan, or doing a procedure like bronchoscopy or biopsy early in these patients, so that you would avoid any delay. And if at all you have a suspicion that this immunosuppressed host has a possible infection, it is important to initiate the presumptive treatment early without any delay, as it could lead to catastrophe if there is any delay in the management. So, to stress again, I wanted to mention that yes, serological testing can be done, but may not always be useful in acute diagnostic management, primarily because they do not often generate an adequate antibody response to infection. So, when you do the microbiological testing, you should include antigen detection tests or nucleic acid detection based assays, along with cultures that are often sent when we are suspecting infection. Just a very brief note on transplant recipients. I just wanted to mention that when we manage patients who are post-transplant, we often worry about allograft loss, rejection in these patients. We often are concerned about secondary malignancies that they may develop or accelerated atherosclerosis and cardiovascular complications. But I want to stress once again that one of the major issues while managing post-transplant organ transplant patients is life-threatening infections. And as you can see here, 67% of the transplant recipients develop infection within the first year post-transplant, and almost a quarter of them, 25% of them, eventually die of an infection. So, infectious complications in transplant recipients who are immunosuppressed is a significant issue which we need to keep in mind while managing, and this would be dealt in detail in a different lecture. Now, I did mention the term net state of immunosuppression, which is something we need to keep in mind while evaluating these patients, thinking how significant is their immunosuppression to be leading to an infection. So, this is a concept that's kind of complex, probably not very well explained, but we need to think of this as a state which combines all states of immunosuppression in these patients. One is the exogenous immunosuppression, if they are on any medications that could be contributing to their immune status being lesser. Neutropenia by itself, and we will focus on an approach to neutropenic patients in subsequent part of this lecture. Any other metabolic abnormalities which could also be contributing to the status of lowered immunity, like protein calorie malnutrition, uremia, hyperglycemia, any of these could also be contributing to the immune suppression. And we must remember that there are certain infections with immunomodulating viruses that could also be adding to the state of immunosuppression, and by this I mean infections with any herpes group of viruses, particularly the CMV, Epstein-Barr virus, hepatitis virus, and also HIV, which we often think about. So, when we think of net state of immunosuppression, basically I mean that all the factors that could be reducing the immunity in these patients should be thought about and may need to be addressed while we are managing infections in these patients. Now, I often mentioned in several slides that drugs used to suppress immunity, the immunosuppressive drugs, could also be making the immunosuppression or immunity lower, leading to more infections. And usually we think of certain infections associated with certain immunosuppressive drugs or while managing some transplant patients. So, in patients who are on steroids, tacrolimus or mycophenolate, we often think of infections that could be linked to defective cell mediated immunity and reduced neutrophil functions, and this could include infections with tuberculosis, Mycobacterium tuberculosis, atypical mycobacteria, Candida, Aspergillus, Nocardia, and also viral infections like CMV, herpes, and also Legionella, Mycoplasma, Toxoplasma, and strongyloidosis. Any of these could happen. In patients with hematopoietic and stem cell transplant, primarily they could have neutropenia as their defect, and in addition also have some antibody defects. And here a lot of the times we see patients developing infections with gram-negative bacteria, Candida, Aspergillus, any capsulated bacteria, and also the herpes virus. So, once again broadly the general principles in managing these patients would be looking at potential etiology for the infections, which obviously could be diverse, and to remind again, rarer organisms, polymicrobial infections need to be kept in mind. They could be community acquired bacterial and viral diseases. So, just because they are immunosuppressed, we do not need to always think of only the rarer organisms. We need to also cover common community acquired infections that could be prevalent in the area where we are treating. Uncommon opportunistic infections that are unique to immunocompromised hosts, and again as I said, depending on which immunity is most affected, you may want to look at what bacteria or virus or fungus they are likely to develop. Remember that a lot of the times signs and symptoms may be blunted or muted, and by the time these patients present, the disease or infection may be more advanced, and therefore we need to treat these patients, immunocompromised patients with infections like a medical emergency, and we have to order investigations appropriately and be much more aggressive in managing them. We mentioned earlier about serological testing. A lot of the times, yes, it is done, may not always be useful, primarily because they may not generate an antibody response, and therefore add tests including antigen detection, nucleic acid detection, and detection based assays, order appropriate cultures, imaging, early tissue biopsies with histopathology, and there have been studies saying that these are the patients where early referral to infectious disease consultants could probably improve outcome in managing these patients. So remember that we need to treat this as a medical emergency and start early appropriate antimicrobials, broader coverage, think about drug interaction in these patients, particularly these patients who are already on immunosuppressants. The level may be increased when we are adding antimicrobials, antibiotics, and that needs to be monitored. There is a high chance of resistant bacteria growing, so we need to understand the antibiogram in your community and think of the resistant bacteria that may grow so that we initiate appropriate antibiotic therapy. We need to involve surgeons early and think about early surgical interventions when appropriate, and more importantly, as with any other patients, yes, go ahead and send the cultures, but once the culture results are back, we need to de-escalate the antibiotics appropriately. Once again, just a summary of what is the likely immune defect in certain situations and what are the common pathogens that are likely to grow. When we have a skin barrier breakdown, like in burns or trauma, a lot of the times we are concerned about organisms like Pseudomonas, Staph aureus, Streptococcus pyogenes, and Staph epidermidis. In patients who have any kind of phagocytic function abnormalities, whether it's due to reduced number or chemotaxis or microbial killing, the kind of organisms that grow may be different, particularly enteric gram-negative organisms, Pseudomonas, fungus like Aspergillus and Candida, Staph aureus, enteric gram-negatives in patients where there is chemotaxis abnormalities, and when there is reduced microbial killing, you could once again see organisms like Staph aureus, gram-negatives, and Aspergillus or Burkholderia. This is just once again a summary. So there are different ways of thinking about this. The idea of this slide is primarily to tune our mind to think of broadly what is the state of immunosuppression, what is the problem, whether it's humoral or it's cell mediated. Think of the common pathogens that could be causing the infection so that you are appropriately covering while you are initiating empiric therapy. We also need to know whether the immunosuppression level is a high level or low level, again depending on what the condition is. So you would think of low level immunosuppression in asymptomatic HIV patients with a higher CD4 count more than 200, or those who are on lower dose systemic corticosteroids, or those who may be taking methotrexate or azathioprine or mercaptopurine, particularly for rheumatoid arthritis or any of those conditions. But you would think of a higher level of immunosuppression in patients who have combined immunodeficiency, those who are receiving cancer chemotherapy, those who are few months after a solid organ transplant, those with HIV with a very low CD4 count, less than 200, and those who are taking daily corticosteroid therapy with doses with the dose being given for more than 2 weeks, and those who are receiving any kind of immune modulators. I'll switch gears and talk briefly about febrile neutropenia, because this is one of the states that I was mentioning about while managing immunosuppressed patients, particularly cancer patients with neutropenia, while they are on chemotherapy. Because the incidence of infection is significantly high in these patients. As you can see, it's almost about 46.3 episodes per 1,000 neutropenic days, or 48.3 episodes per 100 neutropenic patients in one of the studies. And also the risk of infection is correlated with not only the depth, by which I mean the severity of the neutropenia, but also the duration of the neutropenia that they have. And once again, because of the lack of neutrophils, a lot of the times these patients may have different presentations when they have a lung infiltrate or an abscess, or once again they may have a blunted response where they may not mount a fever response. When I say febrile neutropenia, the most important thing that we think about is the granulocytopenia, which is the single most important risk factor for infection in patients particularly with hematological malignancy, but also others who may be on chemotherapeutic agents. 80% of the pathogens from these patients are a lot of the times endogenous microbial flora, which may be spreading and causing significant bacteremia or even bacteremia and sepsis. The most important risk factor for infection is, of course, the degree of granulocytopenia and the fact on how long they have remained neutropenic. And fever develops in all the patients who have granulocyte count less than 100, even for a shorter duration of time. The risk of infection and infection-related mortality increases proportional to the time duration in which the neutropenia is present. This is the Infectious Disease Society of America's IDSA's risk criteria for fever and neutropenia. Once again, easier to think about the low risk patients, those who have neutropenia, but it's expected to resolve completely within 7 days are probably lower risk. Absence of any other comorbidities, and I've listed a whole bunch of comorbidities in the higher risk. So if those are not present, you could say the patient is low risk, and patients with neutropenia who have adequate hepatic and renal function could all probably be categorized as low risk. The higher risk group is those who are likely to remain neutropenic for an extended period more than 7 days, or if they have any of the medical comorbidities that are listed, whether it is hemodynamic instability, mucositis, oral or GI, abdominal or perirectal pain, nausea, vomiting, diarrhea, any neurological changes or mental status changes, those who have intravascular catheter infections, new pulmonary infiltrate, hypoxemia, those who have underlying COPD, or if they have hepatic or renal insufficiency. So, when do you decide on empiric treatment for these patients with febrile neutropenia who requires empiric antibiotic therapy? If they have an absolute neutrophil count of less than 500, or if it is less than 1000 with evidence of a decline over the next 48 hours, along with that having fever, and by here we define fever as a single oral temperature more than 38.3 or more than 38 for more than an hour. And again, we need to keep in mind that sometimes these patients may not mount a fever response. Even in afebrile neutropenic patients, if they have new onset any of the other comorbidities or changes that I mentioned, whether it's abdominal pain, mental status changes, respiratory symptoms or other signs, you need to think of them as high risk candidates and go ahead and initiate empirical antibiotic therapy. These are Western guidelines, and we probably can use some of those, but we need to customize to our local environment. Most of the time when we are initiating empiric antibiotic therapy in the high risk patient group that I mentioned, you can use monotherapy with an intravenous anti-pseudomonal beta-lactam, and the Western guidelines say ceftazidime, cefepime, imipenem, meropenem or piperacillin tazobactam. Ceftazidime may be less reliable as a monotherapy, so in our country we probably would move more towards cefepime or one of the carbapenems. In patients who are penicillin allergic, you can use ciprofloxacin or aztreonam along with clindamycin or vancomycin to cover the gram-positive. Aminoglycosides, fluoroquinolones and or vancomycin can be added for management of complicated patients if you are suspecting antimicrobial resistance. And again, in our country where we do see a lot of Acinetobacter, we may need to target the therapy appropriately. Different regimens may be used, and a lot of the times we do see oncologists preferring to manage some of these neutropenic patients out of the hospitals. If you need to use oral regimens, ciprofloxacin, levofloxacin along with amoxicillin clavulanic acid may be used. And if you are suspecting a higher risk patient or those who are getting hospitalized, we use IV regimens as we already mentioned above. So how long do we continue this empiric antibiotic therapy? So we need to treat them for an appropriate length of time for the particular organism and site, and continue through the period of neutropenia or beyond as necessary. And in patients who have fever of unknown origin, you need to make sure that the absolute neutrophil count remains more than 500 for at least 1 day and continues to have a rising trend, and patient remains afebrile at least for 2 days or longer. I would like to close with this slide, not to describe in detail the immune mechanisms or immunosuppression that leads to infection, but primarily to reinforce the concept that patients who are immunosuppressed may have complex infections. It may be more complex to diagnose the infections in them, and we need to think of it as an emergency and treat them appropriately. Thank you.